Good evening, everyone. We are going to give it about one more minute. I do see participants joining at the moment, so we will give it about 60 more seconds until we start. Okay, we have reached the minutes that we were waiting for participants to join. So thank you all for being with us this evening for this wonderful presentation, which I will introduce our speaker in just one moment. The title of our presentation today is Vaccines New and Old, Preventing Respiratory Infections Across the Lifespan. Before we get started, I do want to touch on a few housekeeping points, if you don't mind changing the slide. Okay, all participant microphones will be muted for this presentation, but feel free to type your questions into the Q&A box for myself as well as for Dr. Hurley to be able to discuss your questions at the end of the session. We will also have a post-webinar survey that will be emailed out after the event, and also we'll have a QR code at the very end. Recording will be housed on the NHPA website and sent out 1 week after the event. You will have to attend the entire presentation in order to receive your CE credit for this presentation. So before I go on, let me introduce myself. My name is Lisa Serrano. I am a pharmacy manager at City of Hope National Medical Center in Los Angeles, California, where I oversee the ambulatory and infusion clinics for the pharmacy department. But most importantly, I am the president for the National Hispanic Pharmacists Association, and I'm very pleased to be with you tonight, but more importantly, to introduce you to our speaker, Dr. Keri Hurley Kim. If you don't mind changing the slide to the next one. So I already touched on the CE credits, and so we'll go ahead and go on to the next slide. And the next one. Okay, so I do want to introduce Dr. Keri Hurley Kim. Dr. Hurley Kim did receive her PharmD degree through Touro University, California. Also received her Master's of Public Health at Touro University. She did go on to receive her PGY1 outpatient pharmacy practice residency experience at Western University, where she has gone on to be very influential within the School of Pharmacies. So first started out as a didactic instructor at West Coast University School of Pharmacy, where most recently she is teaching at UC Irvine School of Pharmacy and Pharmaceutical Sciences. She does have a clinical faculty practice experience in Los Angeles, California at the Saban Community Clinic. And so without further ado, I'll pass it on to Dr. Hurley Kim.
Thank you so much for the kind introduction and all of you for being with us tonight. It's really an honor to be able to, present to your group. I do have to apologize for my voice. I had a few hours of lecture this morning and may or may not be getting sick, so I apologize if it's a little bit difficult to hear, but we will carry on. So next slide, please. See the learning objectives here. I think these may have also been circulated with the flyer. We can go to the next slide. We do have a number of CE questions. We will just kind of read through them briefly at the beginning, and then as we get to the end of the presentation, we'll actually go through in detail and discuss the answers. So the first question here is a 41-year-old female patient with a severe history of anaphylaxis to eggs. She's always been told she shouldn't receive an influenza vaccine. However, the recommendations may have changed a bit. So which of the following would be true based on current recommendations? And next slide, please. And question number 2, our updated 2023-24 COVID-19 vaccines became available in September, and recent data indicate which of the following. This one is going to be select all that apply, so there's more than one correct answer. And next slide, please. Third, studies have demonstrated that RSV, or respiratory syncytial virus, immunizations can reduce the risk of severe RSV-related illness in which age groups? And next slide, please. And finally, which of the following best describes the pattern of disparities in RSV infection among young children in the United States? And next slide, please. All right, so we will go ahead and start with the topic of the day. So we'll discuss a number of vaccine preventable diseases. We'll talk about epidemiology, changes to the CDC recommendations for immunization and vaccination, and then some other kind of topic specific points as well. So starting off with one of our old favorites, influenza. What we of course know is that we have an influenza peak typically every fall and winter. However, since the COVID-19 pandemic, we have seen a little bit of irregularity. Some seasons we have seen an early flu season. Other years we've seen kind of this bi or trimodal pattern of epidemiology. So things have changed a bit, but it seems that they may be normalizing and kind of returning closer to the typical expected influenza pattern, where the timing is roughly predictable and we have peaks of different sizes each year. Next slide, please. We have for the recent past have had quadrivalent influenza vaccines available. This is just a listing of the strains that are included in our current 23-24 formulation. What I would like to note, though, on this slide is that just as of a couple of weeks ago, the World Health Organization and the CDC will no longer be recommending this second B influenza virus to be included in the vaccine. So what we will likely see for the 24-25 influenza season is a trivalent vaccine with 2 A strains and a single B strain. The reason for this is the influenza B Yamagata lineage virus has been seen very, very minimally, if at all, over the past several seasons. So it doesn't make sense to include it in our vaccine at this point anymore. Could change in the future, but do expect to see a return to a trivalent vaccine for this upcoming flu season in the fall of 2024. Next slide, please. What we see for vaccine coverage for this season is that we are fairly, we are almost exactly on par with the last several seasons, particularly in adults. We do know that older adults and our younger pediatrics, so infants and our younger children, have higher vaccination rates than our young adults. However, in no group are we meeting healthy people targets. And then I think it is also important to note that there are a lot of longstanding and still enduring disparities that exist among our Black and Hispanic adult patients in particular, but extending out to the extremes of age as well. Next slide, please. One thing that has changed kind of in stages over the past 5 years or so is this transition where previously we would recommend, because the large majority of our influenza vaccines are grown in chicken eggs, that individuals who had a severe allergy to egg or egg protein or egg products should not receive flu vaccines. We eventually had cell-based vaccines and recombinant vaccines become available that were thought to be safer because they didn't have the same level of contact with chicken eggs. However, what we have learned in the past decade and has now really permeated into the recommendations, is that egg allergic individuals, regardless of the severity of their reaction, can receive any age-appropriate flu vaccine in any setting from any provider. And if you can go ahead and click to the animation. And the reason for this is there is a minimum amount of egg protein that is required to elicit an allergic reaction, even in the most egg allergic patients. And this is about 130 micrograms of egg protein. And this small minimum amount, although it does cause a reaction in a certain number of patients, only causes a reaction in a very, very small proportion of those patients. So the vast majority of people will not even react to this very, very minimal amount of egg protein. And one more click. And then in addition to that, the amount of egg albumin that is actually found in our influenza vaccines is about 100 times, about 10 times smaller than, no, 100 times smaller than this minimum amount that's needed. So there really is not even a theoretical risk of allergic reaction from the influenza vaccines, even in those people who are very, very highly egg allergic. There also have been no documented cases of anaphylaxis to the flu vaccine that are related directly to egg allergy. So we no longer have a concern about immunizing our egg allergic patients, regardless of the setting. What we do, of course, continue to be concerned about is individuals who have had a previous anaphylactic reaction to the influenza vaccine itself. So those people will often be will be considered to have a contraindication to the flu vaccine, but not simply for an allergy to eggs. So you can go ahead and immunize these people in your pharmacies, in your ambulatory care practices, wherever you're giving vaccine, and whatever vaccine you're using for the majority of your patients is considered to be safe. Next slide, please. The CDC does recommend an ideal time for vaccination, so September and between September and October for most individuals. The reason for this is we want to vaccinate a large proportion of the population before flu season really starts to take off. But we don't want to vaccinate so early that immunity begins to wane during the peak of influenza season. There are some exceptions. So for young children who may need 2 doses in their first influenza season, we can go ahead and start a little bit earlier if vaccine is available. Also, pregnant people in their 3rd trimester can receive the vaccine as soon as it's available in order to confer as much immunity as possible in the perinatal period. We also can consider early vaccination for patients who may or may not be reachable during September and October. So if you have patients who may be a little bit less reliable in their follow-up and you have them in your clinic in August, it's probably reasonable to consider vaccinating them at that time, rather than taking the chance that we'll miss the opportunity to vaccinate. We also want to continue to offer vaccine until our supply is either expired or exhausted. So if you're still vaccinating against influenza this month and next month, that's ideal. If it goes on even longer, that is okay. So even though flu season is somewhat tapering off, we have seen this season, a little bit of an extended flu period. And we also know that the more flu vaccine variations an individual is exposed to in their lifetime, they tend to have better outcomes if and when they are infected in the future. So perfectly okay to continue recommending and immunizing through the spring. Next slide, please. So we'll move on then to COVID-19. I think we all are very intimately aware of the epidemiology and when we have seen peaks and surges in viral activity and infections. But what I do really want to point out in terms of the epidemiology is that while we are still seeing fairly significant peaks in COVID-19 positivity and cases, we're seeing a significant separation between positivity rates and hospital admissions. This has a lot to do with vaccines and also the more wide availability of COVID-19 therapeutics, which, while they are underutilized, are still making a difference. And so that's why you start to see that's growing separation between the orange line indicating positivity of testing and the blue bars indicating hospital admission rates. So we are making progress in the pandemic. It is by no means over. We are still seeing, in LA County, we still see several patients dying each day from COVID-19, but we are making progress and being able to prevent some of the worst outcomes. Next slide, please. I do also want to share some updated data related to vaccine effectiveness, and I hope this is something that you can incorporate maybe directly or more likely indirectly into your conversations with patients, because I know a lot of patients feel that the vaccines lack in effectiveness. And one of the big reasons for that is that, many people do still have positive COVID tests even after they've been vaccinated. So I think it's really important to continue with the talking point that the vaccine may not prevent all infections, but it really does a great job of preventing the most serious outcomes. So mortality in our older adults is, depending on the study that you look at, between 7 and 16 times higher in patients who were unvaccinated or not completely vaccinated during our previous COVID season. We also have growing real-world vaccine efficacy data showing that the vaccines are very effective at preventing emergency department and urgent care visits among young children. So this was kind of an open question when the vaccines were approved for this age group, because we had very low case rates and thus a difficult time describing the true vaccine efficacy in our youngest patients. So additional good news in that age group. Finally, vaccine efficacy in preventing hospitalizations in immunocompromised adults is supported. However, the immunity does tend to wane more quickly in these individuals, except that there is an ongoing level of protection, especially against critical illness. So while we may still see a lot of our immunocompromised patients being hospitalized, we're seeing less of them ending up in the ICU and less of them critically ill. Next slide, please. We also have some updated vaccine safety information, and I think this hopefully will speak to additional safety concerns, because I know, among a lot of my patients, safety is really the thing that causes them to hesitate related to the COVID-19 vaccines in particular. So we do have a new formulation of the COVID-19 vaccine this year, the Novavax formulation, which is a non-mRNA based vaccine, which may be an important option for people who have specific concerns related to the mRNA vaccines that we have had during the past few seasons. We have not seen any post-EUA safety signals, meaning that we don't have any indication that there were rare adverse events that were not identified in the vaccine trials. And this vaccine is available for people over the age of 12. Similarly, we have no new safety signals related to the bivalent mRNA vaccines for our older children. And I think it's really important to note that this is based on a very large sample. So while we are by no means immunizing our pediatric patients to the rate that we would like to, we do have a large sample size here, so a large group that are able to speak to the safety of these vaccines. I think it is, when we talk about safety, always important to acknowledge that there may be some serious adverse events related to the COVID vaccines. I think we have a pretty good understanding of a lot of them. So for example, those related to thromboembolic events. However, the key other side of that coin is that those risks and many, many other risks are much, much higher in people who are unvaccinated and become infected with COVID-19. So I think while, vaccines are medications and no medication is free of safety concerns altogether, the benefits far outweigh the risks, and even those very specific same risks. Next slide, please. So the vaccine formulations that we have for this current season are a return to a monovalent vaccine. So these vaccines are based on the Omicron XBB.1.5 variant that was very common last summer. We do have a new kind of cousin Omicron variant that it has replaced XBB in terms of prevalence as of January. However, emerging evidence is showing that the monovalent vaccine that is available today is still highly effective, especially at preventing serious outcomes from COVID-19 infection. We, of course, have our 2 FDA-approved mRNA vaccines. And then in addition, we have the Novavax vaccine, which is new under emergency use authorization. This one is very different in that it is a little bit more like some of our traditional protein subunit vaccines that includes an adjuvant. And I think it is also important to note that the adjuvant that's used in this vaccine is Matrix M. It's related to an adjuvant that's found in Shingrix that we may be more familiar with, as well as one of the new RSV vaccines as well. So this is a newer type of adjuvant, but does not have any safety signals related to the adjuvant itself at this time. Next slide, please. Oh, and the reason that I have the moth there is the Novavax protein subunits are grown in moth cells. So just kind of a little piece of trivia for you. So the bottom line recommendation for fall 2023 and now extending into winter and spring 2024 for the COVID-19 vaccines is that most individuals should receive just 1 dose of the updated monovalent vaccine, whether it be an mRNA formulation or the new protein subunit vaccine, so long as it's at least 8 weeks after their most recent dose. This is no longer an issue, because if someone received a dose 8 weeks ago today, it would have been this updated monovalent vaccine. So that is becoming a little bit less of a concern. But most individuals just need 1 dose. This is true regardless of their past vaccine history, with some minor exceptions. So for our very young kids who are completely vaccine naive or have not received a full dose of, a full primary series of the mRNA vaccine, they should receive that primary series as was previously recommended. We don't yet have data to support a single vaccine in our youngest kids at this time. And then vaccine naive individuals who are going to receive that new Novavax protein subunit vaccine will need a 2-dose series. However, this is only if they're completely vaccine naive and have never received a COVID-19 vaccine before. Additionally, our immunocompromised patients may require additional doses, and the CDC can provide guidance for those individuals as well based on their vaccination history. Next slide, please. When we talked about the influenza vaccines, we were looking at vaccine rates close to 50% or so for our adult population. Unfortunately, the story is very different when we talk about COVID-19 vaccines. So that light blue line there is adults overall. So you can see barely getting to about 22% or so. And then each of the other lines represents a racial or ethnic group. So we see the highest rates of vaccination, in our white non-Hispanic patients, and then lower rates in each group, each other group. Specifically, we have a lot of opportunity to focus on our Hispanic and Black patients who have been under-vaccinated relative to the population throughout the entire pandemic, and even for non-COVID vaccines as well. Next slide, please. I'm going to move on to the respiratory syncytial virus. So this one I'll spend a little bit more time because the RSV vaccines are brand new. So as of May of 2023, we had our first RSV vaccines approved by the FDA, and we now have CDC and ACIP recommendations for our RSV vaccines. The timing is also really important because we have had really severe RSV seasons, especially in our young children and older adults, who historically are the populations that are hardest hit by RSV. But the past two seasons have been really, really severe. So in 2021-22, we saw a really early start to the RSV season compared to historical seasons. We also saw that season go on for quite a long time. Similarly, in 2022-23, we saw returning a little bit more to what we would consider to be the typical RSV season, but again, a really large number of cases and some really scary outcomes, especially in young children. Next slide, please. What we have seen the last two seasons is somewhat of a return in our RSV epidemiology, more towards normal. Sorry, my daughter. More towards normal, where we're starting to see a shift towards that later onset, and more closely aligned with the typical flu season as well. Next slide, please. And similarly to flu, excuse me, flu and COVID-19, we have a lot of historical and worsening disparities related to RSV as well. This study is a little bit older, but the information is still very relevant. The finding being that those infants who were enrolled in Medi-Cal, which is our Medicaid program here in California, had a significantly increased risk of hospitalization for RSV compared to those who were covered by non-Medi-Cal payers. And the paper does go into a number of the potential reasons for this. Parents who work outside of the home, more frequently infants being enrolled earlier and younger in daycare programs where they may be more heavily exposed to all kinds of viruses, but RSV being one of them. So not only do we see racial and ethnic disparities, we see income-based disparities here as well. Next slide, please. And then this slide also looks at the increased rates of RSV hospitalization in American Indian and Alaska Native children. This is a lot more recent information, but seeing in some populations a very significantly increased risk of hospitalization. So this will become relevant when we talk about the specific recommendations for the use of our RSV vaccines. Next slide, please. And this final piece of data related to disparities, this is from a preprint, but it is an NIH-funded study that found that not only are we seeing this disruption in seasonality, which we did discuss just looking at the trend of cases, but we also see worsening in disparities in our Black and Hispanic children. So we see higher rates of infection and also poor outcomes in these patients. So this is definitely something where the pandemic seems to have worsened a disparity again. We're seeing it when we talk about everything from diabetes management to other infectious diseases, but we are, this is just another example of the impacts of the pandemic on our underrepresented minority populations. Next slide, please. So the good news is we do have now some means of prevention. So we have two new vaccines. One is an adjuvanted recombinant vaccine called with the brand name of Arexvy. The other is a recombinant bivalent vaccine called Abrysvo. Both require reconstitution, and they come together with their diluent. In the case of Arexvy, the diluent does contain the adjuvant, so it's really important to make sure that both vials are used together for expected efficacy. Next slide, please. And then in addition to our vaccines, we have one new and one old monoclonal antibody product. These are passive immunization products that are used in infants and very young children. The biggest difference with nirsevimab, which is our new monoclonal antibody, is that it is long-acting. So we've had palivizumab since 1998. However, it was not widely used because it did require repeated dosing throughout the RSV season. So it was only used in the highest risk infants and young children, where nirsevimab, because it can be dosed just once in the RSV season, is indicated regardless of medical history for infants whose birthing parent was not vaccinated during their pregnancy. And we'll talk a little bit more about the specific recommendations. Next slide, please. This just shows the timeline. So you can see there, 1998 was the last time we had an immunization product approved to protect against RSV. And then nothing happened until last year. We had this big flurry of activity. We had 3 new products approved. Abrysvo was approved not only in our older adults, but also to be used in pregnancy. And then we had our monoclonal antibody nirsevimab approved and received ACIP recommendation in infants and young children. Next slide, please. I'm not going to go into every detail of these studies, but I think it is important to just talk about the efficacy for these vaccines. So both Arexvy and Abrysvo were found to be highly effective, particularly in the first RSV season following immunization in older adults. There was some waning in efficacy in season 2. But it seems that efficacy, especially against severe outcomes, is maintained at least to some degree. And there was also no significant difference in safety outcomes between the vaccinated and placebo groups. Next slide, please. So based on these trials and other information, ACIP concluded that both are moderate to highly effective in preventing RSV-associated disease in adults over the age of 60. So their recommendation is that those individuals who are 60 years and older should receive a single dose of either RSV vaccine. There's no preference for either one. It's important to note that the trials were not, the vaccines were not trialed head-to-head. So we can't directly compare efficacy. They were done in different populations, had a little bit different definition for case definition. So the vaccines at this point are considered to be essentially are comparably effective. So no preference for either one in our adults over the age of 60. Using shared clinical decision making. So when ACIP doesn't have quite enough information yet to say, we know this is absolutely effective and absolutely recommended for all people in a given category, they will use this shared clinical decision making element, which I think is really important, especially for a new product, because it really heightens the focus on patient education and allowing that patient to be involved in making the decision with all the information that we have available. Vaccination should be given very similarly to our influenza and COVID vaccines before the onset of RSV season when it's possible. However, if you have a patient who's interested to receive the vaccine today, that is perfectly acceptable as well. And then we also have the blessing of the CDC to go ahead and give this vaccine together with other vaccines. However, evidence is limited to suggest that there is no risk that we know of for vaccine interference. Some of the open questions that we will start to see more and more information are the population level impacts of vaccination. So when we vaccinate our older adults, does this play a part in protecting our young kids? We also don't have information yet regarding the exact duration of protection and whether revaccination will be valuable or recommended in the future. Cost effectiveness is still an open question. So these vaccines being new are quite costly, and we need real world population data to really solidify our understanding of cost effectiveness. Also in the trials, there were small, non-significant increased risk of inflammatory neurologic events. The assumption is that these risks are higher with RSV infection itself, but something that is being investigated further. Next slide, please. Another group that we need to talk about in terms of RSV vaccination is in pregnancy. So when we think of immunizing in pregnancy, think of RSV in the same category as Tdap. So we are administering the vaccine to the pregnant person. However, the object is to protect the fetus after birth. So for these trials, the vaccine, of course, administered to the pregnant person, but the outcomes were assessed in the infants after birth. So you can see there, depending with time since birth, the efficacy of the vaccine. So in their most vulnerable period within the first 90 days, the vaccines were about 82% effective in preventing medically attended RSV. And then with a little bit of waning as time goes on, this is what we expect because this is a form of passive immunization and those antibodies will not stick around forever. Also important though to note that as the infant ages, their risk of serious outcomes with an RSV infection does decrease. And then very similarly to the trials in our older adults, we don't have any specific safety signals in maternal participants or their infants and toddlers, going all the way out now to about 24 months. Next slide, please. This is just a visual to demonstrate the rates of severe RSV and medically attended RSV. So you can see a really clear, separation of those lines. So those receiving placebo having an increased risk all along the way. Next slide, please. So based on this information, our ACIP concludes that vaccination during pregnancy can safely and effectively reduce the risk of RSV infection in infants. So the recommendation is that the RSV vaccine should be administered between 32 and 36 weeks gestation, and this is really specific and intentional. It's also administered only seasonally. So if you have a person who is at 32 to 36 weeks gestation in the summer, they will not receive the RSV vaccine. And then a kind of companion recommendation is that nirsevimab should be administered after birth to that infant if they're born during RSV season and maternal vaccination was not completed. Co-administration is a best practice. This was done in the trials. However, we do have an open question, of course, related to revaccination. So if we know very clearly for Tdap that we can give a repeated vaccination at subsequent pregnancies, but we don't yet have that information for RSV vaccine. So more information to come. And then I do want to just comment on the timing for vaccination. So this is a little bit different than what we use for Tdap. So for Tdap, we have a little bit wider window, essentially anytime in the third trimester before about 4 weeks ahead of the due date. For RSV vaccine, this window is shortened, so only between 32 and 36 weeks. So the 32 weeks is there because in some of the trials, there was seen to be a small and statistically non-significant increase in the number of cases involving preterm birth. So we don't yet have the information to know for sure that this is a causal relationship, but just because that risk is still an unknown, we wait a little bit later in pregnancy to go ahead and give the RSV vaccine compared to Tdap or flu. But then we do want to give it ahead of that 36-week mark in order to make sure that there's time for those antibodies to be produced by the pregnant person and then passed along to the fetus before birth. So a little bit narrower window, something to look out for. Next slide, please. So the last piece we have here is our passive immunization for infants. So we have a recommendation to go ahead and immunize the pregnant person between 32 to 36 weeks, specifically with the Abrysvo brand of vaccination. The other Arexvy has not yet been adequately trialed in pregnant people. However, for infants who did not receive that passive maternal immunization, we have another option. So we now have nirsevimab, the trials showing good efficacy in terms of prevention of RSV, serious RSV infection and hospitalization. Can't really compare head to head with maternal vaccination, but both are felt to be very effective options. Next slide, please. So the recommendations here are for infants and then also children age 8 to 19 months with a severe risk factor. So infants who are not vaccinated infants whose pregnant parent was not vaccinated during the pregnancy should receive nirsevimab regardless of their medical history. However, those children who are between the ages of 8 and 19 months who have any of these risk factors should also receive an additional dose. This may mean that in their second RSV season, these kids are receiving a second dose of nirsevimab. And I think a lot of these are pretty self-explanatory. So, chronic lung diseases, immunocompromised, and then the last one there, the recommendation specifically for American Indian and Alaska Native children is related to that higher risk of hospitalization and severe outcome that we've seen in studies in that group. It is important to acknowledge that the efficacy estimates for high-risk children is based on pharmacokinetic extrapolation. There was a small randomized trial, but we don't have enough data in these groups to specifically speak to a specific level of vaccine efficacy. So while it is thought to be important and effective, this is based on pharmacokinetic information primarily. The safety is comparable to palivizumab, which was typically recommended in many of these children, however, although with repeat dosing, and because of the reduced clinic burden and reduced number of doses, it is more cost effective. Next slide, please. All right, so the recommendation for our healthy infants and young children, which is fortunately the large majority of that group, is that all infants born during or entering their first RSV season should receive a dose of nirsevimab. The dosing is weight-based, and one exception here is those who were born to mothers who were vaccinated adequately during their pregnancy. And then for infants and children who are a bit older at increased risk and entering their second RSV season, they will receive what may be an additional dose. Providers should administer these shortly before RSV season begins or within 1 week of birth if the baby is born during RSV season. Co-administration with other vaccines is perfectly acceptable and considered to be a best practice. However, the one big open question we have here is the real clinical efficacy in high-risk infants and children. And just like any other conversation related to vaccines, especially in immunocompromised patients, this is likely to be variable depending on the degree and type of immunosuppression. Next slide, please. We didn't have time to include a lot of specific information about the pneumococcal vaccines. There have not been specific updates to the recommendations in the last year or so, but it is something that while pneumococcal disease is not considered to be a seasonal respiratory disease, it often gets brought up in some of these seasonal respiratory disease conversations. So don't forget to offer that to patients when it is indicated. And the CDC has this great PneumoRx app that will help in your vaccine decision making for patients who may need that. Next slide, please. So we'll come back then to our CE questions. So number one, this is our patient with a history of severe anaphylaxis to eggs, no other medical history. She's been told she shouldn't receive the vaccine. So which of the following is correct based on the current ACIP recommendations? And you can go ahead and just type your answers into the chat. Yeah, so I see, so for everyone answering D, which is exactly correct. So she can receive any formulation that's appropriate for her age. This is true whether you're practicing in a community pharmacy, in an ambulatory care clinic, in a hospital, a long-term care setting, wherever you are, go ahead and vaccinate her. Perfect. Next slide, please. All right, so the updated COVID vaccines became available in September. Recent vaccine uptake data indicates what? And remember, this one has 2 correct answers. Yeah. So this one, I see A and D, and then I also see A. The numbers did change a little bit since we created these questions. So if you were a student in my class, I would accept either A and C or A alone. So A is still true today. We do have a little bit greater than 20% average vaccination rate in adults. I think the number from the most recent CDC information was about 22%. So creeping up a little bit, but A and C are the selected correct answers there. But if you only chose A, I would accept that as well. And next slide, yeah. So studies have demonstrated that RSV immunizations can reduce the risk of RSV-related illness in which populations? Yep, so I see some answers for D, which is exactly right, so A and B. So while we are administering the vaccine to pregnant women, we actually don't have information on whether or not it prevents RSV infection and severe outcomes in those people. So the target for our maternal vaccination, of course, is those infants. So answer D is correct. And then last question. Which of the following best describes the pattern of disparities in RSV infection among young children? And I see a few of you answering B, which I would absolutely agree. So especially during the last 2 seasons, we've seen not just a higher incidence, but worsening disparities in our Black and Hispanic children. And then A is not quite correct because the impacts of the disparities have been different across different racial and ethnic groups. And that concludes the slides that I have prepared. So I'm looking forward to your questions.
That was a really great presentation, Dr. Hurley Kim. So thank you to all who have participated so far with the CE questions. It was great to see everyone submitting their answers in the chat. I don't see any questions from the group participants at the moment. So if you don't mind, I have a few of my own.
Yeah.
So I know, when COVID started rising and everyone in the medical field, well, it seems like everyone in the medical field was really excited when the vaccine came out, but there was a lot of controversy behind it. And there continues to be controversy behind vaccines. What methods do you take in your own practice to try and distill these controversies?
Yeah, so this is definitely the $10 million question. Unfortunately, I don't have a perfect answer or complete answer, but I think one of the things that is most important is to be as patient specific as you possibly can. So understanding that every patient does not have the same concerns. So some patients feel that it lacks in efficacy. Some patients are concerned about rare adverse events. Some patients are simply concerned about receiving the vaccine and not being able to go to work the next day. That's a big one that I hear from my patients, that, if I miss a day of work, that's a huge impact on my income. I could potentially lose my job. So helping them to address, whatever specific concern it is that they have. And then I think also keeping in mind that a single conversation is not always enough. So just because a patient turns you down today, that doesn't mean they're never going to be vaccinated. And it's okay to continue to bring that up. Some patients will be completely unwilling to discuss the vaccine at all, but some will slowly open up. They will slowly start to let you know their specific concerns so that you can address those. But I think one of the most important things we can do is just let them know, we are a trusted source of this vaccine if and when you're ready, and we'll continue to talk about it at each and every visit.
Got it. So making it more patient specific. And I suspect, this patient specificity is different for different communities because of maybe them disproportionately being affected by health equities and being able to address those kinds of factors. What do you think about that?
Yeah, I think that's absolutely true. During part of the pandemic, I was practicing at an FQHC where the majority of my patients were Hispanic and Black, and of course, underserved, marginalized. And then I was also practicing at an HIV pharmacy in West Hollywood, where the large majority of the patients were wealthy, they were white. And so the conversations that we would have would be very, very different. The concerns are very different, where some patients have a mistrust and, in the medical system in general. For some, it's vaccines in general. For some, it's the COVID vaccine specifically. So really, taking the time to have those conversations. I know time is really, really valuable, but this is something that, I think if we're going to move the needle, it does require those intensive conversations sometimes.
Right. Just like you mentioned earlier, which I had never thought about them missing a day of work after they get a vaccine. And so I'm very sure there's pockets of patient populations where they have, certain things that are top on their list. So it'd be good to be able to come up with, knowing your patient population and how to be able to communicate this with them.
Yeah, absolutely.
Yeah, so I was really surprised by the literature that you demonstrated about the egg allergy. So I know some people really, really focus on that. Is there any specific way that we could be able to share information like this so it's not so scientific for these patient populations to get them more on board and accepting with vaccines and maybe changes in what they've heard in the past?
Yeah, so one way that I actually describe it to patients is to think about, maybe they have an allergy to egg products, even when it's like in baked goods, right? So I'll just have them think about, how much egg protein is in that batch of pancakes or in that cake, compared to how much egg protein could possibly make it into the vaccine. And I think just kind of creating that visual, something that they're familiar with, and, again, something that they may not be familiar with, but they at least can see the volume is so small. And I think that is, probably the most effective way that I've been able to kind of reverse this thinking. And it is something that, a lot of healthcare providers are still being re-educated to understand as well. I know, when we learn something about a contraindication, something that we're taught could hurt someone, it's really hard to move back and to change our thinking on that. So I think it's helping patients to understand, but also helping a lot of our colleagues to understand so that they can be giving consistent messaging as well.
Got it. I did want to touch on the CDC ACIP recommendations because there's so many evolving variants as well as changes in infectious diseases. How is that adaptable to their recommendations?
How do they use the information to adapt the recommendations? Yeah.
Yes, yes.
So I think it is really important to let patients know that the recommendations change because we have and use new information. So if we didn't see recommendations changing from, December 2020, January 2021, in my view, that would be much more concerning because we can all see that the pandemic has changed. We don't see the same rates of hospitalization. We're not seeing the same variants. So the recommendations are changing because the situation is changing, because we're having a better and better understanding of the virus. We have a better and better understanding of how the disease moves through the population. So the change in recommendations, while it seems like, someone constantly changing their mind, what it really is being nimble and responding to new information. It can be a difficult conversation to have with patients because I think a lot of patients had the understanding that I would get a COVID vaccine or a series of vaccine and then I'd be done. And now I'm constantly hearing about another new vaccine, and somebody's trying to sell me another new vaccine for this disease that I don't really see as being as big of a threat anymore. So again, it really goes back to just finding out exactly what is the patient's concern, where have they maybe heard some misinformation that we can, start to correct a little bit. And a lot of that is, talking about how the changes in recommendations are actually a positive thing. It means that we're responding to new information.
That's a great spin to put on it. That is definitely a positive thing, and it's our response to this change. So we are coming up on the hour. I want to be respectful of everyone's time. So thank you to all of our participants. And if we could just move on to the next slides so we could wrap up the session. So we do want you to save the date and register on our website, the network and connect with fellow pharmacy professionals. Our 6th annual conference is going to be at the 2024 APHA conference, March 23rd from 6 to 8 p.m. So if you are there for the conference, please come visit us and learn all about what we are doing for the upcoming year, as well as what our plans are for NHPA, as well as changing the platform for healthcare for the Hispanic community. Next slide, please. Here are our QR codes. Again, thank you so much for spending the hour with us and hearing Dr. Keri Hurley present on this great topic today. We also have the QR code to visit our website. And next slide. And this is to complete our post-webinar survey. Thank you so much, everyone. Have a great evening.
Thank you.